Okay, so I'm doing one last check as I always do for any pulsation, and I don't feel anything. You can see that angle fairly well. It's slightly more superior than it looks on the screen because of the angle. I'm going to pop in. And I'm actually at a point in the temple which is furthest away from where those vessels should be. Aspirate, give it a second, and then I can start delivering my product. Now the next thing I'm doing at this point is watching my patient for a response. A lot of the worst occlusions I've heard of have been really painful during the injection. So anyone who's suffering, I would stop, find another point. Now I'm putting a little bit of pressure anterior to that so that I don't let too much product flow backwards. Temples are a risk because of the volume of the injection. That's why we do the extra steps, which I recommend, like not priming your needle, for example. I recommend you do that anywhere where you're injecting a large bolus. Nice and slow, letting it flow in. I'm actually not putting much pressure on at all. Now I remember from her picture that she had 0 temple before, so I know I can completely correct this. If it flows too easily and it's not very, doesn't project very well, like Volift or any softer products, it may not actually do the lifting we want. So when you get a bleed like that, we need to hold it for at least a minute. Having a peak a little bit too soon always backfires, doesn't it? I know from experiences, I usually do half to 1 mil at a time. Now there are occasionally you have, I've been on these expert panels where they decide like what's safe. And they throw numbers around like how much should you put in one area. My experience of that is that there really isn't anything other than thought around that. There aren't any cases of people putting 2 mils in and causing pressure that blocks an artery, and people with 1 mil never having that problem. It's just not known. So I think what happens is there's a lot of kind of the kind of realm that you play, the volume that you're used to putting in is what you gravitate towards. I nearly always use a needle because I can place it deeper on the periosteum. I do use cannula sometimes. The slight risk is kind of bogginess. It's quite thin skin, so you can end up a little bit boggy, which some patients complain about, but it's low risk. So unprimed needle, feel for any pulsation. So it's the left side, sometimes a little bit more painful. So once again, angled. So I'm going into the little V shape by the bone, and I'm angled towards the bone. So if I go too deep, I'm not going to be in the wrong place. Aspirate, that's a negative, and then start delivery. So I don't want to move my tip again. Once I've started injecting, I don't want to move it again. I'm monitoring Lindsay's response to see if she reacts differently. In answer to the cannula question, I have done that multiple times, but I wouldn't try and correct the whole temple with a cannula currently with the way I currently see it because of the bogginess, but I might do a little bit over the top to kind of smooth something in to get the final bit of the result out. That would. So how does temple affect eyebrows? You can sometimes get a lift from eyebrows. It's that stretching effect which we talked about before. You can sometimes relax orbicularis oculi through expanding the tissue here, and it just releases some of those fibers, and you get a little bit of a lift in some people. So I can really see this is less of a risk now with her cheek. This is flowing more gently, and I can go on to the next phase. So I'm going to use Voluma now let's go for a long 25 gauge cannula. So I'm going to now attempt to lay the first layer of support for her cheek. So I'm replacing that lateral fat pad. I'm going to put a cannula in and do a little bit just on top here, just a first pass, and I'll probably adjust that again later on. Pilot hole, I'm trying to aim it in the direction my cannula is going to go, and I only need to go through the dermis. I don't need to go through everything, and that's enough for me. I'm now in the hypodermis, in the fat. So getting your cannula in, I see all sorts of ways of getting it in, as in there's this kind of stirring thing with a needle where you put the needle in and then go round and round and round. My idea of what's going on there is the sharpest bit of the needle is doing something underneath, and then the blunt bit that's not really that good at stretching the skin is just going round and round. So it's not necessarily that effective, and mostly I don't think you need to do very much at all other than just aim properly. Just pop a little swab on top of that. Anyone who's seen me do this before, I think I'm unusually gentle compared with many. I really don't like the idea of tearing through to get somewhere. I like to try and find an easy route. So I'm just trying lots of different angles, maintaining my overall direction of aim and trying to sneak through without causing any trauma. And we're right back now. So now I'm right where I want to be. I'm on the superior surface of the zygoma. And this is where, particularly with a cannula, it's very sculptural. I'm just kind of, it's a lot like shaping a, if you're a sculptor and you're chipping away a bone, but it's the reverse because it's additive. But I'm just adding little bits. I'm seeing what the result is like. I'm checking it, doing a bit more, and just gradually increasing the volume. This is Voluma as well. So I'm also, having asked that question about the temple, I am actually slightly in the temple now because I can see a little shadow from where I'm at. I don't know if you can see it, where I can just see the connection between the cheek and the temple, and I just think I'm going to smooth that slightly. But going back to how we started, I have an aesthetic goal, which is I want this to project out a little, but not too much for the temple. And I'm continuously referencing that goal as I'm going. I use what I can see in terms of visibility of the cannula to adjust, to decide where the product goes. As the cannula bulges, I think, yeah, that's what I want to achieve. Let me do a little bit of smoothing. So the next thing I'm going to do, which is harder for you to see, is do some anterior cheek projection. I just know from if you turn your head a little bit to the side, you might see that this area is projected more further forward than up here. So I'm basically trying to get the cheek to project a little bit more like that. And that's part of what will help lift the lower face as well. So with this, I prefer to do deep, and it's onto the anterior surface of the zygoma. You can feel the angle of the zygoma here. So what I'm now seeing in my mind's eye is this alignment with the zygoma, but I'm on the anterior surface. So looking at the skeleton, you might be able to picture that it's the anterior surface of the zygoma I'm trying to augment. Now the artery, as we've said, it runs medial to it, the facial artery, and then beneath it or inferior to it as the transverse facial arteries. This is a relatively safe place to go deep and touch the bone. Aspirate. Okay, and then a little bit of molding just to shape that in. So now we'll do the same on the other side. Your supporting hand is very important for cannulas in terms of feeling where the product is going, adjusting the tissue as you're sliding in. Finding that easy route. I think of painting often the way I layer the product. I'm just trying to layer evenly and sculpt that shape. It's adhered. It's underneath the structures, but it's not. Most cannula procedures are in the hypodermis. You can be in deep hypodermis or superficial hypodermis. And it's actually why quite often I do quite like using needles to get a little bit deeper. But it's pretty hard with the cannula, even with your best interests, best attempt to go very deep. So where is it good to be deep? Particularly where you might have a little bit of puffiness occurring. So usually in the tear trough, we want to be a little bit deeper. And I'm going to do a little bit in the lateral lid cheek junction just to blend the cheek in with a couple of injections of Volumization. Now these I want to be on the periosteum, so much safer in terms of the puffiness that you might get. It's a better place to have them. So lateral lid cheek junction is a really important part of periorbital restoration. I still see people treating the tear trough as if it's a different entity, and you see the medial aspect of the tear trough improved, and then they leave the lateral aspect. That's it's down to a training gap, because the lateral lid cheek junction is usually more aging than the tear trough, in my opinion. So I'm just trying to get, there's a little line I can see. I don't know how well you can see it on the screen, but I just want to get that little line to project up. That little shadow there is really important for overall restoration. So once again, I'm aiming in such a way that if I go too deep, I'm not going to hit an eye. One of the cases of blindness, temporary blindness, thankfully, was on a tear trough course where they went on the medial border of the bone and then injected the, I think, criminal artery. So if I angle in such a way that if I go too deep, there's no way I'm going to hit anything other than bone, that's exactly what I want to achieve. So I'm going to go. Also an unprimed needle is pretty superficial. .05 might be my first pass. Now I'm going to change angle, trying not to bruise by going through the same hole and now remembering what I noticed about the slight downturn to her eye, I might attempt to just give a little bit of a lift to the lateral part of her eye, but it's this, you can't see it so well on here, maybe on this side you can see it, there's a little tiny shadow just there, that if I can get that to look slightly more like that, it will give her a more positive aura instantly for a very small amount of product. I can't see it, I think the light is hiding it, but I can see it from where I am, so we'll do a little tiny amount with that. So I'm looking for little superficial veins. I'm going to enter. I'm on the periosteum. Absolutely must touch bone around here. And I'll do a little squirt, 0.05, and then shape that. So first pass, I often use a finger, and then I use the cotton bud. It's just easier to flatten something in a cruder way with your finger, and you get the sensory feedback from using your finger, and then the cotton bud just allows me to roll it in a way that fingers are a little bit less good. So once again, you're looking for those little veins to avoid. This is a bit of a bruising area. Touching the periosteum. Now some people have a little shape in here, and it can look like you're expecting to hit the orbital rim, and actually you don't. And you can go in and hit the eye. So I'm always very slow as I enter in there, because it's quite rare, but I've had them where you feel, in fact, Lindsay has a tiny hint of one. There's like a little dip in the skull, and I've had a couple of patients where that dip is quite basically pronounced into a V shape. So if you feel above and below, you expect there to be bone, but actually underneath there isn't. So that's very important to know about. It's not that common, but it does happen.